Good morning, everyone. A warm welcome to all of you for this first clinical contact session of this clinical management of HIV course of 2017. We have been repeatedly discussing that these clinical contact sessions will be important for us to attend, and the way these sessions have been planned is to help every one of us out in terms of understanding the lectures which were already done by the University of Washington faculty and putting those lectures in context of the national scenario. So we very well know that the guidelines which are followed in the US are not the same as we follow here in India. So the way we have planned this session, this particular session, and similar sessions will happen over next 10 weeks. That's next 10 every Saturday at the same time. So it is expected that every one of you should be able to access the Canvas, which is University of Washington course website. And these two lectures, which are there on the screen now, the names of the lectures are there on the screen now, have been already conducted and recorded links have been uploaded on the Canvas. So it is expected that all participants should listen to these lectures first before participating in clinical contact sessions of Saturday. So my name is Dr. Anwar Parvez Syed. I am Senior Medical Advisor and I work for iTech since over 4 years now. So the topic for this week has been diagnosis and initial management of or initial evaluation of HIV positives. So on this topic there were two lectures which were conducted by the UW faculty, Dr. Nina and Dr. Allison. The first one was the newly diagnosed HIV infected patient, and second one named initial evaluation of HIV infected adults in resource limited settings. What I've done is I've mixed slides of these two lectures with the NACO slides so that it will give us a holistic picture towards what exactly is to be done and what the course is offering us. Listening to these lectures is also important in terms of solving quizzes, because all those questions you will see, the answers to those questions will be found in these two lectures, most of them. So if you have any difficulty, feel free to type your questions in the chat box, and if you want to make any comment, or if you think that there is any other better way of conducting these sessions, you are most welcome to give your suggestions. We thought that this will be helpful, that we mix NACO guidelines with this so that it should not be on another tangent. We should also know the practical aspects of the topics which we are dealing with in the course, and that is why we have tried to mix it up. Okay, let's start and then see. Towards the end you can give your feedbacks so that we can still further modify this weekly clinical contact session, so that we should be able to present you the national scenario or the NACO guidelines along with those important issues which were brought about by the University of Washington faculty. So in the first lecture it was the main issues or the main aspects of initial evaluation which were discussed were how to receive a patient who has come to your OPD, and we need to verify their HIV testing report first, test result first, and then staging the patient as per their clinical stage, and to understand the necessary aspect of the clinical examination, history taking and physical examination. And also the laboratory test which we offer to these patients, initial laboratory test, that is baseline investigation we call it at our ART centers. What are the international guidelines for initiation of antiretroviral therapy? We'll also touch upon what are the national guidelines, but we'll not go in details of ART in this session. Next session will be on ART, so there we will have more elaborate discussion on ART aspect. And also what are the other things in addition to the treatment which will help our patients to do better in their life. So all these aspects have been very nicely discussed and explained in those two lectures done by the university faculty. We'll try to see how that can be implemented in the national scenario. This case was presented by Dr. Kim, a 22 years woman presents for your care at your clinic. She was diagnosed 2 years ago in local public health clinic. She has presented for testing after discovering a partner who is HIV positive. Now, such patients or such clients, they keep coming to us at ART centers also. So, what questions do you have for her? So, this opens up the discussion in terms of whenever a new patient comes in to our OPD or ART clinic, what are the initial questions which come to our mind and why? First question is, what does the person knows about HIV? This also Dr. Kim was stressing upon very much, that it is very important to find out from the patient that what is their opinion about or what is their understanding about being HIV positive. Sometimes people misinterpret the result itself. If someone says that you are positive, people take it in another way, like being positive is something which is good. So that should not happen. And believe me that this happens. This is not from imaginations, but this has happened before, that if you say someone that you are positive, people might take it in a better way or in a good sense. So we need to understand what a person means or what a person thinks about his or her own HIV positive status. You need to ask questions that what is HIV positive, or what does this being HIV positive mean. So that is one thing which is very important in the initial aspect, and also it will give you an idea regarding the further steps which we will be taking in terms of management of these patients. So if not everyone will be mentally disturbed or will be under stress after knowing their HIV status, to some patient it doesn't really matter. They take it very lightly. So don't introduce your fears in their mind that you will die soon and all those things. That should not be done. So first try to listen to the patients, that what they think about being HIV positive mean. So, and what does they know about HIV, or what do they know about HIV? And second thing is, how did she contract HIV infection? Now, this question is tricky. Most of the times, what I have observed, people who do not usually treat HIV, their curiosity is for some different reason. They just want to know that how the person has acquired HIV, and there is no action after that. But unless this is linked with some action, this question doesn't really matter, because for a clinician or for a physician, it doesn't matter that a person has acquired HIV from sexual route of transmission or through injection drug use or blood transfusion. HIV positive will remain HIV positive. But for assessment of risk factors, this is very important question to be asked. So you should not be asking this question in terms of interrogating a person that you want to know about the status and then forget about it. No, the reason why we ask this particular question, that how did you contract HIV, is very clear, that we want to assess the risk factor so that this person, this particular client, will not get any super infection or repeated infection or any STI or any other issues which are related to the risk of or behavioral risk. So that is the reason we ask this question. But unless people are clear about the reason for asking these questions, the meaning may differ. So this takes us to modes of transmission of HIV. We very well are aware that there are, most broadly if you see, there are 4 modes of transmission. Sexual route through semen and vaginal secretions, sharing needles and syringes. This is not needle stick injury directly. Sharing needle is different from needle stick injury. That's why these two things have been kept separately in this slide. Needle sharing is something which is very risky. If someone have seen how these people who inject drug, they are called as PWID. Earlier they used to be called as IDUs, injection drug users. Now the current term which is being internationally used is PWID, that is people who inject drugs. So these PWIDs, they share their needles or drugs, because drugs is injectable drugs is expensive, and they don't want to spend much money and they share the drugs. And when they share needles, there is a risk of cross transmission from one person to another, because they just pull the blood first in the syringe and then push just to ensure whether they are there in the vein or not. So this causes this infection, or this route is dangerous, because also it brings up or brings them to the risk of other infections like hepatitis B, hepatitis C, and others. So that is people who inject drugs, or the transmission risk or transmission through sharing needles. Needle stick injuries usually happen at workplace, for example, hospitals or other dispensaries. So that is one, but risk of transmission is low. I'll come to the risk of transmission in the next slide. Then through infected blood and blood product, if someone is injected with HIV positive blood, then there is very high risk of HIV transmission, almost it is 100%. Then the mother to child transmission. From mother to child, the transmission can happen during pregnancy, during labor, that is at the time of birth, and during breastfeeding. So transmission risk is different from one another if you compare these transmission routes, which is very important for us to know and remember at least some figures, some numbers, because it will help you to counsel a patient. For example, if suppose a person comes, for example, some intern comes to you, or some nurse comes to you with needle stick injury. Is the risk of needle stick injury similar to what a risk is when a person shares the needle who is from the group of PWID? Answer is no, it is not. Is the sexual route of transmission risk same as the through blood and blood products? It is not. So we should know that what is the percentage of risk of transmission, so that you will be in a better position to explain to people, especially in needle stick injuries and also in case of pregnant women and breastfeeding women, because the counseling is most important thing in these three at least. Of course, rest is important, but these three can be, again, you need more knowledge for explaining these people regarding transmission risk. Now this is a slide which I was talking about. You need to remember at least some numbers. Like I said, blood transfusion risk of transmission or HIV transmission risk is more than 98%. Practically it is 100%. If you are injecting a person with HIV positive blood, then the risk of transmission of the receiver will be almost 100%. Then perinatal, the risk is 20 to 40%, that is from mother to child risk of transmission. Of course, the risk during pregnancy, during labor, and during breastfeeding, it differs. So the highest risk in that is during labor. Now this will be covered in detail in a separate session on PMTCT. So I'll not go in details of this at present. Sexual route, if you see, most of the people, they think that if they have sex with HIV positive person, they'll get HIV even if once. But surprisingly, that is not the case. If you see here, it is 0.1 to 1%. That means you have sex with HIV positive multiple times, there is very small risk that HIV may get transmitted from one person to another. But then why is it so that most common mode of transmission is sexual? Because now all the other modes of transmission are may or may not happen repeatedly, but sex is one thing which repeatedly happens. It is a normal physiological activity which everyone does. Now because of this repeated exposures, risk of transmission increases. That is one reason. Second reason is, if suppose a person's viral load is very high, who is not on treatment, it is more likely that that person will infect the other more as compared to the other person who is virologically suppressed. Third reason is, if suppose a person is having STI or other genital infections, that will increase the risk of transmission to the person who is HIV negative. So, and in the sexual intercourse also, if you look at vaginal intercourse, anal intercourse, and oral sex, the risk of transmission during anal sex is highest, that is 0.5% if you see the upper limit, and then vaginal, and then oral. Obviously, because anal mucosa is more fragile, and also there is more in terms of blood supply also, if you see, there is more chance of injuries where the risk of transmission increases. Injection drug use, it is 0.67%. Needle stick injuries, now this is very important to remember, 0.3%. That means if you have a needle stick injury with HIV positive needle 100 times, there is again 0.3% or 0.3 times it is, or if you increase 10, that is 1000 times, then it is only 3 chances that a person will get HIV. But you don't know which chance that is, but this will help you in explaining to your to a person who comes to you or reports to you the needle stick injury. So this will calm them down that this is not that if I have I get a needle stick injury, I have become HIV positive. That is not the case. Then mucous membrane splash to the eye, it is 0.09%. This also happens especially at the time of pleural fluid aspirations or other things like that. When you push in the outlet, sometimes it get disconnected and splash will happen over the face. This is not very uncommon. It also happens. People who work in the hospitals, they know, who have seen the patients in the wards, they very well know how this happens. Let's see some epidemiology, some numbers about AIDS epidemic. These numbers were released by UNAIDS in 2015. These are the current figures. So as per them, the estimated HIV, all these are estimates. Estimates are based on some studies which are done to know the burden of the disease. Now this is prevalence. For every one of us, most of us are clinicians, so sometimes we forget the words like prevalence, incidence and all that. Just to remind them, prevalence is nothing but it will tell us the burden of any disease. So when we say prevalence of HIV is this much, that means number of people living with HIV at present are these much, estimated to be. So 1 million is equal to 10 lakhs, that means 36.7 million equals to 3 crore 67 lakhs of HIV positives. That is a global estimate of HIV. And if you see the adults and adult women, women is almost now over half of the overall adult population. That means it is not only men's disease, it is equally in women. So people who think that most of the HIV positives are men because of high risk behavior, so that is not exactly the case, and there are multiple reasons. I'm not going in this, but one thing is very sure that half more or over half of the HIV positive estimated population is women. So it becomes very important that the strategies which are meant or which are implemented to deal with HIV should include special requirements for women also. So those women, because sometimes their needs will be different, their problems will be different, like stigma and other things and all those issues. So especially when in a family, if suppose a person who is diagnosed HIV positive first is a woman and then husband is diagnosed, then it becomes a nightmare. Even if suppose person who is the husband has acquired infection first and women is diagnosed first, then it completely changes the scenario. People will start blaming women and all those things will happen, and that is why it is not less number, it is almost half of the population, HIV positive population is women, and that is why special steps need to be taken to tackle that or to deal with them. New infections, like I said, the other term incidence is nothing but number of new cases happening in a population in a given time. So in 2014, if you see, the new infections are 2.1 million, those are per year. AIDS related death is 1.1 million. Now how this prevalence changes is either the new infections are being added in this population or deaths are happening from this population, which will reduce this number. So if our objective at present is we don't want people to die, obviously, so deaths should not happen or they should be minimized, and new infections should be minimized. If you want to reduce number of HIV positives, you can do two things: either more people should die or new infections should be lessened, or less and less new infections should happen. So obviously we will not like people to die because of HIV. So the second option to reduce the prevalence of HIV is reduce the new infections. Now how we reduce the new infection is what all this course is about. So we will diagnose people early, we will put them on treatment, we will reduce their viral load so that they will transmit infection less. all that start with diagnosis of HIV and initial evaluation of the patients. So this will be explained in details again in the future slides. This is same thing which is explained in different pictorial form. If you see, these are the two regions where we are interested in and where the most of HIV positive burden is there. So if you look at the national scenario in this, the percentage wise, if you see, the India's prevalence is 0.26%. This was by HSS, that is HIV Central Surveillance Survey. But because the denominator is huge, because we have a huge population, even if the number is high, that the percentage will still become low. In terms of numbers, if you see, we have almost 2 million HIV positives estimated population in the country. So 2 million is a huge number, that is 20 to 21 lakhs. So which comes to 0.26% in terms of percentage. This estimated population or estimated prevalence, again in male-female comparison, if you see for national scenario, it is 0.30% in males and 0.22% in females. But the prevalence is on declining trend over a period of time. If you see from 2001 to 3 until 2015, it has been decreasing from 0.38% to 0.26% now, and similar consistent declines are noted both in males and females at national level. The same thing has been explained here, 0.34 and 0.26%. There is a declining trend of HIV prevalence in the country. Now, if you compare these three pictures from 2003, 2006, 2015, what has happened is you will see more this dark brown or chocolatey color, if you say, is more than 1% HIV prevalence. Red is 0.5 to 0.99% HIV prevalence, and yellow is less than 0.5% prevalence. Initially, we used to say that there are 6 high prevalence states. If everyone remembers earlier days, 4 in South India and 2 in Northeast. But slowly scenario changed. People migrate, they do migrate, and also all these efforts have happened for reduction of prevalence. In high prevalence states, if you see, the prevalence is declining. It is less than 0.5%. But if you see this and compare with this, now everywhere HIV you will see in some or the other number. That means there can be two possibilities. One, the data which was not available earlier, now it is available. Second, again, there are certain states which are called as highly vulnerable states, where the prevalence of HIV may go high if steps are not taken at appropriate time. So this is one thing which is important for us to know, that all districts of India have been divided into 4 categories. That is category A, B, C and D. And category A is where the prevalence is very high, which is more than 1%. And in your own state, you can ask your DAPCO also that what is our district category, so that you will also know that what is the burden of the disease in your own area. This is again estimates. If you see now, as AP has been divided into Andhra Pradesh and Telangana, Maharashtra becomes now number 1 in terms of prevalence, and then which is followed by AP and Telangana. Then also these states which earlier we used to say that Tamil Nadu, Karnataka, they have high prevalence, but again, as I said, it is in declining trend. Gujarat, Bihar, these are new states which have come up with increasing or with prevalence of HIV which is high at present. So these are highly vulnerable states where steps have to be taken, and these are the other states where HIV prevalence is might increase if steps are not taken. Now, routes of transmission, as we already mentioned, that most common mode of transmission is sexual, which is 94%. That is 94% of the people who have acquired HIV during 2012 to 2015 or in over a period of time, if you see, they acquired HIV because of sexual route of transmission. At least they have reported like that. So, and which is very logically it is true. So most common mode of transmission is sexual. This is SIMS data of NACO. And other routes of transmission, if you see, the blood and blood products, injection drug users, parent to child transmission. And parent to child transmission also, it has reduced over a period of time. Now it is reported to be 3%. Earlier it was 5%, and during 2012 and 13 to 2014-15 it has reduced from 5 to 3%. There are some specific groups of people who are considered to be high risk groups, or KPs, key populations, and ANC, that is antenatal clinic or antenatal mothers, are representative of general population because they are not ill and still they go to the hospital. Easier population to test for HIV. So ANC represents the prevalence of HIV in general population. The female sex worker, MSM, IDU and transgenders, these are high risk groups. Migrants and truckers are considered to be bridge population. Bridge which connects high risk group with the general population. So in all these groups, if you see, the prevalence of HIV is either stable or reducing. Especially in IDUs, if you see this slide, you will understand better that in ANC we already saw that prevalence have reduced over a period of time, and in the other high risk groups also it is reducing, but in IDU if you see, it is stable. Let's come to the pathology or pathogenesis. So in terms of how the virus infects a person, whenever there is sexual activity between HIV positive and negative person, HIV makes contact with the cells located within the genital mucosa. So from these cells in the genital mucosa, those are dendritic cells. From these dendritic cells, they will take HIV to the regional lymph nodes within 1 to 2 days. In the regional lymph nodes, there will be exponential multiplication or replication of the virus, and these viruses are released into the blood or blood stream, and where it will go to the all organs. It can directly attack the organs, some of the organs also. Same thing explained in the form of picture. Exposed to HIV at mucosal surface, that is during sexual intercourse, because HIV is there in fluids, in vaginal and seminal fluids or semen. Then these dendritic cells, they will take the HIV and they will be carried to the regional lymph nodes where HIV multiplies in the CD4 cell. I'll come back to the what happens in the CD4 cell in the next slide. But when this exponential multiplication happens, huge viral load or amount of virus is released into the bloodstream, and within 5 to 11 days HIV will reach all parts of the body. Now this diagram is very important in terms of understanding, not only understanding the life cycle of HIV, but also in terms of understanding the action of antiretroviral drugs. We'll repeat this also in the next session of ART, but for now let's try to understand the life cycle of HIV. This is HIV virus, which has a single stranded RNA and 3 enzymes in it. The 3 enzymes are, one is reverse transcriptase, second is protease, and third is integrase. So when HIV, and firstly, what is CD4 cell? CD4 cell is nothing but a T lymphocyte. You all know that there are WBCs, RBCs. In WBCs there are, if you see, remember the differential of WBC, you have lymphocytes, monocytes, or neutrophils, eosinophils, basophils, all those things. In lymphocytes, there are 2 types of lymphocyte basically, T lymphocytes and B lymphocytes. T lymphocytes are responsible for cell-mediated immunity, and B lymphocytes are responsible for humoral immunity. That means antigen or antibody formation is being done by the B lymphocytes. Now T lymphocytes are mainly called as helper T lymphocytes, which are main defense mechanism of the body. Now those T lymphocytes which have a receptor, that is CD4 receptor on their surface, are called as CD4 cells. So CD4 cells are nothing but a type of T lymphocyte. These are also called as CD4 type of T lymphocyte or helper T lymphocytes. Now HIV requires the CD4 receptor to get attached to the CD4 cell. That is why it will attack only this type of lymphocyte or only this type of cell. So HIV will get attached to this CD4 receptor. There will be 2 more co-receptors here. Those are called CCR5, CXCR4. I'll explain them in detail again in the next session on ART. When this happens, this single-stranded RNA comes or is released into the cytoplasm of the CD4 cell along with the three enzymes which we named before as reverse transcriptase, integrase and protease. As we all know that it is a single-stranded RNA virus which gets converted into double-stranded DNA, and this important conversion is brought about by the enzyme reverse transcriptase. So now reverse transcriptase, when does this single double-stranded proviral DNA is formed, which is transferred into the nucleus of the cell and which is integrated into the human DNA. This is human DNA, this is viral RNA. So this is proviral DNA, again having genetic information of the HIV virus. Now this is incorporated into human DNA, or this is integrated into human DNA by the second enzyme which is called as integrase. When cell activation happens, then this information comes out in the form of messenger RNA, which gets translated to form the viral proteins. Now these viral proteins will be in the longer shapes and size, which are cut down to the appropriate size viral protein by the third enzyme which is called as protease. Now all these three enzymes will ultimately help this RNA or these proteins to get converted into proteins which were required to form a new virus. Now these proteins will take the cell membrane and come out as a new virion, and in a day multiple times or even in lakhs the new copies of the virus are formed. Now what has happened in all this process is HIV is a virus which has used this CD4 cell of the human being as a workshop for production of many copies of the virus. ART does the same thing. These three enzymes like reverse transcriptase, integrase and protease are blocked by antiretroviral drugs. I'll come to these details in the next session. So this is life cycle of the virus, and when this happens multiple times, as I said, lakhs and lakhs of times in a day it happens, and new viral copies are formed. Now as a result of this, viral load will go on increasing, and as this cell was used multiple times beyond its capacity, it will die off. And this is what happens is slowly viral load will increase and number of CD4 cells will drop down with time. That's it. That is the life cycle of HIV. If you see in terms of stages, it is viral transmission, then acute retroviral syndrome. This is something which will be again coming back to in the later slides, which is also called as a acute HIV infection in the initial stages of HIV infection, a flu-like syndrome. Then seroconversion from HIV positive to HIV negative through antibody-based test. Then asymptomatic chronic HIV infection, which can happen from 8 to 10 years. Then symptomatic HIV infection. This is generally a course of untreated HIV infection. This graph is also very important. If you see here, there are three lines: red or pink line, blue line and dotted green line. The pink line is your viral load. If you see in the first few weeks, viral load will jump very high, then it drops down, because when body's immune system comes into action, comes to know about this new virus which has come into the body, it will try to drop it down, and it will drop it down to a certain level which depends on again humoral immunity or strength of the humoral immunity. And sometimes it will bring it down to very low level, and on that low level a person will survive for years and years together, which is asymptomatic HIV infection. So this level to which the viral load is dropped, it is called as virological set point, which varies from patient to patient. Now it depends on what level this virological set point has happened, which will ultimately lead to a person who end up having AIDS. If virological set point is higher up here, then person will land up in stage of AIDS early. That will happen in usually rapid progressors. But if it goes down for very down, then for a long period of time, which is long-term non-progressors, a person will be asymptomatic without any problem, CD4 will be good and everything will be fine. So it depends again how strong the immune system reacts. Now the second graph is regarding the CD4 or immune cells. Now there will be initial drop of CD4 cells, and then it will get stabilized, and ultimately slowly it drops down. So whenever there is a drop in CD4, it will be at the whenever there is a rise of viral load, it will be at the cost of destruction of CD4 cells. That is why you will see it inversely proportional to each other. The antibodies are not formed initially for few weeks, but once they are formed, they will usually remain for lifelong in a person's body. So this is a typical course of untreated HIV infection, but when you start treatment, all this gets reversed. That means viral load will come down and CD4 will go high. Now these are the patterns of HIV progression. There are typical progressors. 50 to 70% of the people will be typical progressors. That means the rate of drop of CD4 cells in those people will be 35 to 50 cells per year. And this develop end-stage disease. People develop end-stage disease within 8 to 10 years after seroconversion. This is typical course. But in some patients, you will see they will land up in stage of AIDS very fast. Those are called as rapid progressors. About 10% of the people this happens. The rate is very fast. Rate of CD4 drop is very fast. That is 50 cells per month, which is very rapid. They develop symptoms of AIDS within 2 to 3 years also. And also in children, they progress very rapidly. Then slow progressor, 5 to 15% people will fall in this category. Rate of drop of CD4 is very, very slow. They will remain symptom free for long time, that is 10 to 15 years. See, this happens in some of the patients. They say that, okay, we are not on ART, we are not doing anything, still nothing is happening to me, or still there are no signs and symptoms, since 20 years nothing has happened to me. So people will try to make it a case, or others will feel like, okay, if it has not happened to the other person, why should I take all this ART and other things? So for them to explain them, you should able to explain them with these figures, numbers. If you know this, you will be very well in a good position to explain to your patients that this is not the case with everyone. In some exceptional cases, like 5 to 15%, this can happen. And there is another group of 5 to 10% which is long-term non-progressors. There is stable CD4 count years together, like more than 15 years also, nothing will happen to those patients. So this information will help you in counseling those patients who are not ready for ART as a result of someone who told them that I'm not taking ART, still I'm good. So you should be able to explain them that that is not the case with everyone. Now there is a strong association between OIs and CD4 count. We are very well aware of this, that whenever there is a drop of CD4 to less than 200, the more and more risk will be there for development of opportunistic infections. So even in less than 200, there are, if it is very, very low, less than 50, there are some specific OIs risk will increase, that is cryptosporidium parvum, and then that is cryptosporidial diarrhea, or CMV. CMV may cause retinitis or other manifestations. Then MAC, which is Mycobacterium avium intracellular complex. Then PML, which is leukoencephalopathy, and also the toxoplasma cryptococcosis can happen if the CD4 is less than 100. Risk of PCP, esophageal candidiasis, mucocutaneous herpes can be there when the CD4 drops below 200, and there are some OIs which can happen at any CD4 count. One of which is most important, that is tuberculosis, which can happen at any CD4 count. But the severity with which it happens, it differs if the CD4 count is very low. If suppose CD4 count is less than 200 or less than 100 or 50, then it may be the presentation will be different than the development of TB at higher CD4 count. When CD4 is low, there will be a disseminated kind of TB involving CNS and other things, where diagnosis becomes difficult, and then again treatment sometimes becomes difficult because of risk of iris will increase, and all those things will happen. It will be a complicated disseminated tuberculosis. While if the CD4 is good, it will be like any other non-HIV or immunocompetent person, upper lobe and involvement and all that. And pulmonary TB is most common at that time, and if CD4 is low, disseminated tuberculosis is more common at that time. So we were talking about a patient which Dr. Kim mentioned that this woman, she brings in lab result from the ICTC, we can say, where she got tested in early 2011. Her CD4 count was 300. She reports no HIV associated illnesses. When did she contract HIV? What stage of HIV she is in? Now, why this information is important, that when did she contract HIV, and why this clinical staging is important. We will try to answer how first, which we were talking about. Actually, this slide should have come early. By mistake, I have put it here. So we were talking about how a person has contracted HIV. It can mean because the risk factor wise, if you see, this person was injection drug user for 10 years, had unprotected sex for money, and also she had contracted HIV long back, but results but did not report to the health facility early. But her last HIV test report was negative for about 4 years ago. This will generally give us idea that what time a person might have acquired HIV infection. You can see the last negative HIV report, when was it, and then uh, it is high probability that seroconversion might have happened later. This will help us in counseling patients in a better way. Now, um, also, if suppose a person gives history of flu-like syndrome, which as I mentioned before, it happens in the initial HIV infection, where the it is like any other flu-like symptom, like myalgia, fever, headache, body ache, all those, and sore throat or rashes, that can happen. So when there is a new patient who comes to you, you can ask about these questions, that did you experience anything of this sort in last 6 months or 1 year or 2 years, or like that. If they say that there was some episode like this, sometimes, or most of the times in fact, this will go unnoticed. People will not go to the doctor also for at this time, where they get symptoms like this, like initial flu-like symptoms. So uh, there can be a generalized lymphadenopathy, or also at that time, mainly because of, we saw that exponential multiplication of the lymph nodes, which happen of HIV will happen in the lymph nodes, which will increase the size of the lymph nodes also. There will be headaches, malaise, anorexia, lethargy, and rashes may happen at that point of time. Now, though it is important, or it will be good if someone can diagnose HIV at this point, but it is difficult to diagnose HIV at this point, because most of the settings in which we are working in, where the testing will have the antibody test available to us, antibody will not be positive at this point of time. And in fact, if you see the this is some skin lesion, or skin lesions of primary acute retroviral syndrome. This is also oral ulcers of acute HIV infection. If you see here, some oral ulcers, you will be able to see. So the testing which is available to us, I'll come back to this type of testing also in the next few slides, but basically we have antibody based test, antigen based test, and also we have RNA based, that is nucleic acid based test. So I'll come back to this in very shortly. Why this early diagnosis of HIV is important? Obviously, because if a person is HIV positive, there is a risk of spread of HIV from that person to another. As soon as you put the person on ART and you reduce their viral load, their risk of transmission of HIV to the others will be reduced. So ART will become one of the uh, best possible helpful strategy for reduction of transmission risk. So as soon as you find out a person, immediately, or if the ART is started early, and if a person, when becomes viral load becomes suppose undetectable, then risk of transmission from that person to another person will be reduced drastically. And that is actually the theory of behind giving ART to all ANC mothers at present in our guideline when we are following. So when we give ART to all pregnant women, so risk of transmission will reduce drastically to their babies. So this is risk of HIV transmission by stage of HIV infection. This is important again to answer to those who say that if my test result is negative, I'll operate that person without any problem. Why I'm specifically trying to mention this is even now I've seen people rejecting surgeries for some or the other reason whenever they find out that a person is HIV positive, which actually should not happen, but unfortunately that happens. So if you see here, in the first few weeks of acute HIV infection, the transmission risk is really high, because viral load will be very high at this stage and antibody based test is negative. So even if suppose pre-surgery or before surgery, if you do HIV testing and if report is negative, people should be actually in fact more worried than a person who is at this stage where the viral load is low and your antibody test is positive. Because irrespective of the fact that a person is HIV positive or negative, the universal safety precautions should be followed by any person who is doing surgery. Of course, when there is a stage of AIDS, viral load will increase. So putting patients on ART early will help in reducing again transmission risk. Now this is how virus looks like. There are some important proteins. If you can remember names of these proteins, it will be well and good, like GP41 and GP120. So these are the two important envelope proteins, GP160 which is called. So this is very important proteins which you will also see in Western blot report. If this is positive, there are great chances that a person might be HIV positive. There are other antigens. You can see here one of which is very famous P24 antigen. And there are three enzymes which you can see here inside. Essentially HIV is RNA virus. Along with that, as I said, there are three enzymes, that is reverse transcriptase integrase and protease enzyme. So these are the types of diagnostic tests: HIV antibody test, that is serology; viral antigen test, that is P24 antigen; viral DNA, that is DNA PCR, polymerase chain reaction; and viral isolation and culture. Now isolation and culture, obviously it doesn't happen in routine practice. It is for research modes and other things. Viral DNA is expensive, and DNA PCR, it is done in the program but reserved for specific situations like pediatric HIV and others. Then viral antigen test, or this P24 antigen, it is not done in the program. I'll explain the reason why it is not done. Then HIV antibody test or serology, which is most commonly done in the national program. If you see this slide, you will come to know that how these things they behave. Like if you see the HIV proviral DNA, it has a window period. See, every test has a window period. It doesn't mean that only antibody based test have window period. It is not like that. Even DNA PCR will have some window period. So if suppose I get a prick today, or if HIV enters in my body today, I will not be tested as HIV positive by any mean today itself. So unless that window period is passed by, I will not be able to, or my blood test will not come as HIV positive. So HIV proviral DNA, unless it is formed, which will happen between 2 to 3 weeks, my test will be negative even for DNA PCR. So immediately after having prick, the test we do is to rule out the baseline, or what is the status at the time of infection. It will not tell you the infection which might have happened because of this particular exposure if you do the testing on the day of prick. On the day of prick or exposure. So similarly, if you see the viral load, it will have a window period, and also, but if you look at the P24 antigen, as I said before, initially there will be a rise in P24 antigen, but then there will be a fall, and sometimes, or most of the times, it will be disappearance. So if a person is tested with P24 antigen initially, that person might get tested as negative if P24 antigen is done after a period of time, like after say 6 months or 1 year, this person may get tested negative with P24 antigen testing. That is why it is not reliable test to do. So HIV antibody test is considered to be very reliable. Once antibodies are developed, they will be there in the blood for lifetime. Or HIV proviral DNA also will be there, and viral RNA will be there if it is not suppressed. So the test for diagnosis are screening test, or antibody test, rapid test, enzyme link or ELISA test. Then there are certain tests which are called as confirmatory or supplemental test. Second and third rapid ELISA test to confirm first HIV test, and then Western blot test. Basically how it is done is initially rapid tests are done in our program, and if the first rapid test is positive, then again it is reconfirmed by another test with different principle. The screening, these are very sensitive tests, and but for all tests, and if the second sample is positive, again the third test is done to confirm the positivity. All these testing are done on the same blood sample in the lab. So rapid tests are line test. Immunochromatography is the principle on which it works. Lateral flow devices. You will see the markings, or you will see the control and test lines, there will be a control line and test line which will be compared to interpret the test results. Similarly, there is a the tri-dot test where there will be a control, and this is for HIV1 and HIV2, and whichever color matches with HIV. See, this will have antigen. Your or blood, if blood sample, if suppose have antibody, when a drop of blood is again comes into contact with this, there will be antigen antibody reaction, and there will be change in color, and the if it changes color and if it matches with the control, then it is interpreted as HIV positive. So HIV positive 1 and 2 can be initially diagnosed by using tri-dot. ELISA is again very reliable, but again the problem with ELISA is it requires technical expertise and also setup which is not available everywhere. So that is the reason we do rapid test in our program, which is easy to perform. But again, benefit of ELISA is multiple samples can be processed at the same time. It involves some steps like washing, reading, and then again interpretation of result is not as straightforward as we do in the rapid test. There are certain new tests also which are there in the market, like OraQuake or oral the mucous membranes. You collect swabs, and then you can do testing at home also, but they are not very well encouraged here at present. But in high prevalent countries, it is being used. But those are again screening tests. Whatever happens to them, it has to be confirmed in the laboratory after that. Window period, we already saw that it is a time period between time of infection and point at which the evidence of infection is detected. That is, test comes positive. It is different from the test to test. For example, if you are using HIV P24 antigen, as I said, it comes and goes. So window period will be initially in days. But if you are using, suppose ELISA generations, if there is right now it is 4th generation ELISA which is used in blood bank, you can minimize the window period. So higher the generation of ELISA you use, you can minimize the window period, and earlier you can diagnose the HIV infection. So there are 3 strategies for HIV testing in India. There is blood transfusion or organ donation, where there is strategy 1 is used, which means you do one test or single testing is done, and then based on that the results are interpreted as positive or negative. It is done in blood bank. If the donor checks on the box where it is written that my report should be informed to me, then only the lab informs the donor that your blood has been tested HIV positive. Otherwise, it is not informed. Then strategy 2 is usually used for surveillance purpose, like HSS and all we spoke about, which is unlinked anonymous. So 2 tests are performed in this. Strategy 3 is used for diagnosis of HIV, where We use this voluntary counseling, and informed consent is taken and confidentiality is maintained. It is done at ICTC. First test is done. If first test is negative, then no further testing is performed in on that sample. Report is given as HIV negative. If first test is positive, then second test is performed. If suppose in this second test, one as first was positive and second turns out to be negative, then also the third test is performed. See, and if suppose the first test is positive, second is negative, and third comes positive, because third test is used as a tiebreaker. If all three are positive, then there is no problem in reporting. The sample is reported as reactive to HIV antibodies. But if it is the case where first is positive, second is negative, third is positive, or first two are positive and third is negative, then it is interpreted as indeterminate reports. And if it is indeterminate, then again further testing is required to give the report on this sample. But as I said, if first test is negative, no further testing is done. But in some situation, all the three tests have been are necessary to be performed. For example, in terms of 18 months testing for babies, where all the three tests are done. Where if the first test is positive and second and third are negative, then non-reactive to HIV antibody is interpreted. For intermediate test report, then Western blot is performed at the state reference lab. Now, you can stage every new person or PLHIV who is coming to you based on two basic staging methods or classifications. One is by CDC, which is 2008 CDC classification. Second is what is being used by us in India here, which is called as WHO clinical staging. It is important for you to know the CDC classification. One is for information, but also it is important because there may be one question in the quiz also based on this classification. So stage 1 is CD4 more than 500. Stage 2 is CD4 between 200 to 499. Stage 3 is CD4 less than 200. But stage 3, if it is along with clinical evidence of AIDS defining condition. We'll see the WHO classification in a few. More details because we use them routinely. In WHO clinical staging, there is a difference between adult and pediatric staging. We'll see that differences also while doing this. Clinical stage 1 is essentially asymptomatic. Clinical stage 1 is similar for adults and pediatric. When a person does not have any signs and symptoms, it is called as asymptomatic. Or if a person has persistent generalized lymphadenopathy. There is a definition for persistent generalized lymphadenopathy. There is painless enlarged lymph nodes more than 1 centimeter size. The lymphadenopathy in 2 or more non-contagious sites, that is excluding inguinal area in absence of any other cause. And if it is persisting for more than 3 months, 1, 2, 3, more than 1 centimeter, involving more than 2 non-contagious sites, and persisting for more than 3 months. It is called as PGL. If a person is asymptomatic or having PGL, the person will be staged in WHO clinical stage 1, which is same for adult and pediatric. Stage 2, there are few exceptions in pediatric. First we will see adults. Broadly, if you see, there will be moderate unexpected weight loss that is less than 10% of the body weight. You will see minor upper respiratory tract infection and minor skin infections in stage 2. In minor upper respiratory tract infection, you will see recurrent infections like sinusitis, tonsillitis, otitis media, pharyngitis. These are all recurrent minor upper respiratory tract infections. Then minor skin infections like herpes zoster, angular cheilitis, recurrent oral ulceration, papillary pruritic eruptions, or PPE it is called. Then fungal nail infections, which is onychomycosis, seborrheic dermatitis, or you can say dandruff. All these are minor skin or skin appendages infections. So these conditions, if a person has any of these conditions, will be staged as stage 2. There are some exceptions, something which is there in pediatric which is not there in adults. One is unexplained persistent hepatosplenomegaly is stage 2 in pediatric. Then lineal gingival erythema. This is on the gingival border, you will see redness. There is a clear demarcation or clear markings near the tooth of on the gingiva near the tooth. You will see a linear marking which is called as lineal gingival erythema. It can be seen again in children. Then extensive wart infection, wart virus infection, extensive molluscum contagiosum. Again, molluscum contagiosum, I'll show you. There are some slides on that. Then unexplained persistent parotid enlargement. So that is also one of the condition which, if it is seen, you can label the child as stage 2, WHO clinical stage 2. Then stage 3, you will see unexplained severe weight loss, more than 10% of the body weight. Then chronic diarrhea for more than 1 month, chronic fever for more than 1 month, unexplained persistent fever for more than 1 month. You remember these three in one succession, like weight loss more than 10%, chronic diarrhea more than 1 month, unexplained fever for more than 1 month. I'll tell you the reason why. Then persistent oral candidiasis. Now remember, this is persistent oral candidiasis, not just once. If a person has, suppose, some red, some whitish in the mouth and it disappears, that is not persistent oral candidiasis. Even bad oral hygiene will cause oral candidiasis. So that should not be reported as stage 3. But if a person is having persistent oral candidiasis, that should go in stage 3. Then oral hairy leukoplakia. Now candidiasis, you can read more about it. It has again 4 different types. I will not go in details of that here. Then oral hairy leukoplakia, it has, the people will have vertical corrugated markings on the lateral aspects of the tongue because of Epstein-Barr virus. So that is called as oral hairy leukoplakia. And pulmonary tuberculosis, severe bacterial infections such as pneumonia, empyema, pyomyositis, bone or other joint infection, meningitis, etc. All that fall under stage 3. There are certain other conditions also, like acute necrotizing ulcerative stomatitis, gingivitis, periodontitis, unexplained anemia, that is less than 8 hemoglobin, but it should be unexplained. So all that will form under stage 3. In children, if you see how it differs, is unexplained persistent diarrhea. Here we see for more than 1 month. In children, it is more than 14 days. And also lymph node tuberculosis is stage 3 in children, while we say that extrapulmonary tuberculosis is stage 4. But that is in adults, and in children, lymph node tuberculosis is stage 3 condition. And also there are few additional things like symptomatic lymphoid interstitial pneumonitis. This is an interstitial disease where you will see interstitial infiltrates on chest X-ray and all, and child will complain of breathlessness and all. So that is symptomatic lymphoid interstitial pneumonitis. Then chronic HIV associated lung disease and including bronchiectasis. This is again lung conditions. Now stage 4 list is again elaborate, where all kind of serious disseminated infections, if you talk about, all those will fall under stage 4. Now first of stage 4 condition, if you see here, is wasting syndrome. I was talking about that, you remember those 3 in sequence, that is weight loss more than 10%, fever more than 1 month, and diarrhea more than 1 month. So wasting syndrome, how we define it is, if there is weight loss more than 10% plus unexplained diarrhea for more than 1 month, or fever more than 1 month. So weight loss plus either fever or diarrhea for more than 1 month, this condition is called as wasting syndrome. PCP is stage 4, then recurrent severe bacterial pneumonia stage 4, recurrent herpes, esophageal candidiasis. Oral candidiasis we saw in stage 3, esophageal is coming in stage 4. Pulmonary TB we saw in stage 3, extrapulmonary TB is coming in stage 4. Kaposis sarcoma or other cancers also will fall under stage 4. Cytomegalovirus, CNS toxo and crypto also form in stage 4. HIV encephalopathy, HIV induced nephropathy, all those will form in stage 4. PML, progressive multifocal leukoencephalopathy, stage 4. All serious kind of disease if you see will fall under stage 4. But you can have a printout of this and you can have it under your table just to refer whenever it is required, because again list is exhaustive. So, and in children, how it is different in adult and children is unexplained severe wasting, stunting or severe malnutrition not responding to standard therapy will fall under stage 4. So HIV wasting syndrome, in children we don't see the weight loss, but if it is poor weight gain or if it is wasting or stunting of growth or malnutrition is recorded, then it is recorded as stage 4 condition. In adults also, if you see, there are additional few things like recurrent septicemia, invasive cervical cancer, atypical disseminated leishmaniasis, all that will form in stage 4. In all serious kind of infection, if you see disseminated infections, fungal infections which are disseminated again, malignancies, CNS infection, extrapulmonary tuberculosis and recurrent difficult infections to treat, all fall in stage 4 conditions. There are a few case studies here just to revise what we tried to discuss during the clinical staging thing. This is a 29 years old HIV positive woman who has this painful ulcers which are again vesicles. So these are again 3 days duration, and obviously the diagnosis is very clear from here that it is herpes simplex labialis, will form under WHO clinical stage 2. This is again herpes zoster which is there in a young adult, which is involving the this is involving again a dermatome which is a lesion over the intercostal nerve, and this is herpes zoster, as we saw, is WHO clinical stage 2. You can write the WHO clinical stage in the chat box once I am showing these slides. So this is very obvious. It is again a candidiasis. On the left side you can see the candidiasis involving the oral mucosa. On the right side it is involving the dorsum of the tongue, and also it is involving soft palate and maybe the pharynx. So left side can be WHO clinical stage. I think some people are typing. Can you tell me which stage it is? Yeah, so it is stage 3 and stage 4. And what is this? Yes, it is oral hairy leukoplakia. Like I said, it is on the vertical corrugated markings on the lateral aspect of the tongue. It is WHO stage 3 and it is caused by Epstein-Barr virus. This is an X-ray of 22 years old male with HIV presented with fever. You can see a cavity, if you can appreciate here on the left upper zone, and this most probably cavity because of TB, and if it is pulmonary TB, it will form in WHO clinical stage 3 exactly. Now here you can see homogeneous opacity involving the left mid zone and left lower zone. Actually inhomogeneous opacity, which is again still hurting the left cardiac border, and with some air bronchogram also is seen in this X-ray, which is more indicative of lobar consolidation or pneumonia. If it is repeated consolidation or lower respiratory tract infection, it is WHO stage 3. PCP usually doesn't present as consolidation or pneumonia like this, because PCP is most commonly seen as an interstitial disease. So you will see more interstitial markings or prominence of the interstitial markings in PCP, and slowly there will be ground glass appearance. So that will happen, which can be again seen in severe PCPs. You will see perihilar lesions and all. But here you can see a clear demarcation of demarcating lines, and more commonly, or this presentation is more in favor of pneumonia than PCP. I'll show you also how PCP looks like. This is again a lymph node, which is cervical lymph node, and multiple lymph nodes. There is a matted multiple lymphadenopathy with loss of appetite, loss of weight. More commonly or mostly it is TB lymphadenopathy, which is stage 4. This is again a CT scan picture of where you can see a ring enhancing lesion. If it is suppose toxoplasma or tuberculoma, there can be multiple differentials of this. Again, it will form under, as rightly mentioned, stage 4. This is again a stool sample examination or microscopy, where person was admitted with chronic diarrhea. Modified ZN staining was done, and which revealed oval shaped oocysts, which are Cryptosporidium parvum, suppose. When it is Cryptosporidium parvum, what will be the WHO clinical stage? It will not be stage 3. Cryptosporidia, yes, it is stage 4. You can refer to the list. There is no harm in referring to the list. Whenever you have with you, you can keep it for reference. It is not necessary to remember each and everything. You can always refer to whenever patient comes to you. There is no problem with that. Now, I'm reading this case. 37 years old HIV positive male presenting with fever for last 40 days, lost 9 kg in last 3 months. Previous body weight was 75. That means it is more than 10% of body weight. Treated for TB 5 months ago. What will be the clinical stage? Some say stage 3, some say stage 4. If I say stage 4, then what could be the condition here for saying stage 4? Obviously, TB is not present now. It was 5 months ago. Exactly, it is HIV wasting syndrome. Those who are saying stage 3 are not exactly incorrect, because if you see these conditions separately, both of these conditions will fall in stage 3. But as these two conditions are in the same patient, please remember the definition of HIV wasting syndrome, which says that when there is weight loss of more than 10% along with fever for more than 1 month, that is HIV wasting syndrome, which will fall under stage 4. Okay, so this is the definition of wasting syndrome. 12 years old girl with HIV presented with dry cough, tachypnea, dyspnea and cyanosis. And clinical examination revealed bilateral crepitations, and X-ray looks like this. X-ray you will not be able to appreciate much here because picture and smaller window. But if I say that there are some interstitial shadows here, and sometimes it looks absolutely normal. Here at least you can see some perihilar opacities. So this is typical presentation of PCP, as many of you are writing in the chat box. There is a in PCP there will be indolent fever, that is fever for few days. There will be dry cough. There will be tachypnea and dyspnea, or at least if suppose dyspnea is not at rest, and if you ask person to walk a bit, and after that if a person suppose develops dyspnea, it is more likely that person might have PCP, especially those. See here, CD4 count will guide you for in making the diagnosis. We'll go in details of this in OI sessions and all, but if the CD4 is low and you see patients with all this, you can interpret as PCP for these patients, and especially when oxygen saturation is dropping like this. Here you can see that this patient presented with cough, fever, dyspnea, and 7 days duration. Millet seed-like nodular lesions distributed in both lung fields. What is this? Miliary TB. Yeah, it is called as miliary mottling. We will not jump onto miliary TB as such, because again miliary mottling can be because of many reasons, out of which one of the reasons is tuberculosis. Again, it is extrapulmonary because it is in the interstitial. It is not. The TB is not in lung parenchyma, but it is in interstitium. So miliary TB, and also when it is seen, because there is a hematogenous spread. See how you need to understand how this miliary TB happens. There is a dissemination of Vigard's focus. Through Vigard's focus, TB bacilli are entered into the bloodstream, where there is like you say septicemia. Similarly, there will be mycobacteriemia. So Mycobacterium tuberculosis is disseminated through the blood, and through that route it reaches this interstitium, which means that TB is in blood, and which is spreading everywhere. Wherever blood goes, it will carry TB bacillus along with it. It usually happens as a secondary dissemination in people, which may cause TB in liver and other organs also, but you can see only in this X-ray as miliary mottling, and that is the reason this falls under stage 4. Though you see on the chest X-ray, it is not as a pulmonary TB, it is disseminated TB, and it goes in stage 4. What is this? Now, if I say that this is TB or caseous necrosis of cervical lymph node in a child, then what clinical stage it will fall in? Exactly, it is stage 3. Please don't, because this is what is different from adult and pediatric. I requested you to remember this as a separate thing. TB lymph node or cervical lymph node in children will fall under stage 3 and not stage 4. Okay, so this is the common, actually. Usually we report as extrapulmonary TB as stage 4, but specifically for this, you need to remember that in pediatric it will fall under stage 3, the cervical lymph node. It's a common thing to happen, so don't worry, you will remember it soon. If these children, they have hepatomegaly and hepatosplenomegaly, then, and it is unexplained hepatosplenomegaly, which clinical stage it falls under? Stage 2, exactly. Not stage 4. It is not stage 3. Now all stages are coming in. So it is stage 2. We already saw that list initially. There it falls under stage 2. This is again one thing which is only in pediatric we put under staging, but not in adults. Hepatomegaly or hepatosplenomegaly in pediatric, unexplained hepatosplenomegaly will fall under stage 2. Wasting syndrome, if it is so, then it is stage 4. That is, I agree with you. If you are saying stage 4 because of wasting syndrome, but as we don't have details of it, but I agree in terms like you are saying all this rib cage and all that. It might fall under stage 4 if it is wasting syndrome, if poor weight gain and all of that, and which is becoming obvious. But actually, point why this case was introduced here was to show the hepatomegaly, and if there is only hepatomegaly, then it will fall under stage 4, stage 2. But if you consider it as a wasting syndrome, it will obviously go under stage 4. So whichever stage is higher, we will put the patient in higher stage. So this can be one learning from this slide. If suppose a person is having stage 2 because of hepatomegaly, but also wasting syndrome, which is stage 4, then you need not write stage 2 and 4. You will write only stage 4. Now, what is this? Now, these are the lesions again which are multiple pearl-like, skin-colored. These are again dome-shaped papillary lesions, varying in size. Yes, these are lesions of molluscum contagiosum. And you can see this here. There is a parotid enlargement. Also, in these in pediatric cases, this can happen. The last point we had seen in some stage. Which stage is it? Yes, it is WHO clinical stage 2 for both parotid enlargement and also molluscum contagiosum. Thank you for your responses. So this is how we stage a person whenever he or she comes into the clinic. If a person is on ART, suppose, when a person comes in first, we need to do WHO clinical staging at every visit of the patients. So whenever patient comes, we do WHO clinical staging. So if people are, suppose a person who is having pulmonary TB get registered into the ART center, in the WHO clinical staging I will write stage 3. Now patient is on treatment. Now after some time TB is again, now treatment is completed or cured, whatever, then person is absolutely asymptomatic. You will write WHO clinical stage 1. But in meantime you have started, suppose, patient on ART. So if a person goes on ART, then while writing WHO clinical staging you will write T staging. T stands for treatment. So in the initial stage patient improved, suppose, and if patient is on ART, you will write staging as T staging. Asymptomatic, then instead of writing WHO clinical stage 1, you will always write T1 or T1, T2 if a person develops any stage 2 conditions. Please remember that T is used for those patients who are on treatment. Again, going back to our patient, which was discussed by Dr. Kim in her presentation, her CD4 was 300, and she was diagnosed actually early, but she didn't report back to the clinic. What would compromise your review of symptoms, and what would you pay particular attention to on general examination? So there are few things which should not be missed while doing examination. First is history. Detailed clinical history need to be taken. Please remember this thing, that whenever I understand that ART centers are busy, you will see hundreds of patients in a day, you don't get time, you take lunch at 2 o'clock, all those things I understand, but all patients are not similar. That also you need to understand. All patients are not similar. All patients cannot be seen in 2 minutes. All patients cannot be we can provide consultation without doing any examination on them. So you need to prioritize those patients who are stable on treatment, those patients who do not require much attention in terms of counseling and all that. You can easily, or you can see those patients quickly within 2 to 3 minutes. But new patients have to be given time. New patients have to be examined in detail from head to toe. You will require at least 15-20 minutes for each new patient. So if you have 2 to 3 medical officers, divide your role in terms of seeing new patients and follow-up patients. There are some category of patients who will require more time, in which first one is new patient. Second one is immunological failure patients. Third one is LFU who is brought back. Those will require more. Fourth one is ANCs who will require some, again, time, at least initially, where we explain everything to those patients. HIV, TB, those also will require some time. So we need to plan our timing accordingly, so that new patients at least will be, slowly what happens when you work in the program, you become like you just prescribe medicines and you forget the basic medicine. So please don't forget that. Examine patients, ask history in detail, and then where you will record the history of present illness, constitutional symptoms and all that. Then dermatology is important in HIV. You will see the skin, where you can find out so many things by just looking at the skin and skin lesions and markings of the previous lesions. Then lymph node examination, which is in general examination, you see head, ear, eyes, nose and throat. All these are very important because of specific OIs we just discussed and which can be seen in all those places. Pulmonary and or system examination like pulmonary, gastrointestinal, genitourinary and neurologic examination. All these systems are important for specific reasons to find out specific diseases. Pap smear history for blood transfusion. Pap smear is important, especially in female who are more than 40 years of age. Wherever the facilities are available, it should be done. Flu syndrome history, as I said, sometimes patient don't remember, but if patient gives history, it is good to take those that history. Then history of blood transfusion, again in risk factor assessment we do that. Now, what about vaccines? This slide is again was copied from Dr. Kim's lecture. The practices are not same in the National Program of India as they are in US. So, which vaccine should a patient receive today? This is actually in their scenario they give vaccine for these patients, especially pneumococcal vaccine. The answer for this is pneumococcal vaccine, which is very helpful because of the reasons like the risk of pneumococcal infection is very high in HIV positives. So they gave it to everyone. Influenza vaccine is given annually. Also, tetanus, diphtheria, pertussis is given annually. Hep A, Hep B, these are also given to those patients who are non-immunized. And HPV vaccine is given, mumps, measles, rubella if the CD4 is more than 200, and varicella vaccine, not for zoster, but varicella vaccine is given to susceptible persons with CD4 more than 200. Now again, why I included this slide in our discussion is also because there can be a question on this in your quiz, so you should not again miss that question. That is the reason I included in this. But otherwise, as a program, if you see, we do not have these vaccines in our program, which is again because of multiple reasons, which I don't want to bring them here in this discussion. But for information, you should know that pneumococcal vaccines are beneficial for the patients. Now, what next we do as we were talking about clinical history, physical exam, and baseline investigations. So, in clinical history, when you talk to these patients, as I said, new patients will take more time. First question will be, how are you and how are you feeling today? And see, asking about today is really helpful. It is not a person, suppose, who is ill since last 6 months, getting some problems or some symptoms on and off, will not be able to tell you properly. If suppose 4 days back I was fever and today I do not have anything, or if 4 days back I had fever, yesterday it was low and now today it is again, there is some, I will get confused in presenting myself to a doctor. So today's interpretation of signs and symptoms is important. So that we need to ask. Then weight loss, patients might not be in a position to tell you exact weight loss because most of them they do not know. So you can ask indirect questions about losing of clothes and all those things. Then and these things will be helpful to ask, or you can see the photographs of before and now. All those things can be helpful. Are you able to work? So this will tell you regarding mobility of the patient, and then seriousness of physical again inability to work, and all that can be recorded from this question. Have you ever been hospitalized? Again, this question will help you to get more history. If you are open and if you ask open-ended questions like general questions, they will give general answers. If you are specific, they can give you more information about their diseases. Then any fevers, cough, night sweats. These days we do 4 symptom screening of all patients who come to us. So we will do 4 symptom screening here also for TB, like fever, dry cough, weight loss and night sweats. So ever been diagnosed with TB, any diarrhea, more than 3 stools per day, loose stools per day, any genital discharge, itching, ulcers, other STI symptoms. I am pretty sure that most of us are not asking these questions. And even if we ask, you can again evaluate your own selves how far you are asking these things to patients. But I urge you to ask this at least to the new patients. Please give more time and don't miss any of these questions. Any skin problems or zoster. Now these are very helpful and direct questions which will tell you many things which will be helpful in management of these patients. Don't just be mechanical at ART centers. Keep your medical skills open and practice them. Use stethoscope, use torch, functional torch should be there in the ART center, and see their oral cavity, examine the genital area for STIs and other things. Especially for new patients, you need to do thorough examination. You should have that facility at least in your ART clinics, curtains and other things which are required. So, but don't leave it. Otherwise, you will lose interest after some time while working at ART center. If you are just giving ART and just being mechanical in terms of following guidelines, you will lose all clinical skills you already have. So please don't do that and practice this, especially in the new patients. In the history, there are specific things which you can ask about. That is TB, HIV-related comorbid conditions like jaundice, dyslipidemias and others. Sexual history becomes important in HIV, like history of multiple sex partners, genital ulcers, other STIs. Then personal history like smoking, alcohol, substance abuse and other things can be asked. Family history, TB and HIV, then in family can be asked. Then treatment history, it becomes very important, especially history of ARVs. Sometimes they receive ARV but we don't record them in section 4 of the white card. So all this information is to be recorded in the white card, and if people don't know, please see your white card properly. There is, after section 7, section 8 to 11, you will have space for all these things to be written in the white card itself. Section 7 of TB will have details about TB. Section 4 of the white card will have information regarding past history of antiretroviral drugs. This history is very crucial in terms of further line of treatment for such patients. Then behavior or psychosocial assessment, educational level of the patient, employment. Though we record this, sometimes this is not reliable, so properly that history need to be taken. Social support or family history, especially regarding positive status in the family of the spouse or children and all that. If that gets updated, for example, today patient comes in and spouse test is supposed status is unknown, spouse was not tested. In the section 3 of the white card, you will write spouse test result is unknown. But your counselor will ask that person to bring the spouse later for testing. That will happen ultimately within a week or so. But when the person's spouse is tested, that status which was unknown in the white card section 3, that is not updated. So this should not happen. So whenever you have white cards, when you see this periodically, please have a look at the family history section, where you will see status of the children and the spouse. If it is unknown, then ask your counselor to update that status. So it cannot remain unknown for lifelong unless the patient is dead. Then physical examination, weight, height, body mass index, and then vital signs, that is temperature, pulse, respiratory rate, blood pressure. Now blood pressure is something which I have never seen people taking in the ART centers. After sometimes we will also forget that also. So please don't do that. At least new patients, you record blood pressure. These days even young people are getting high blood pressures, and especially when we are using more and more this lopinavir, ritonavir and PI based regimen, there are high chances that there will be lipid abnormalities and people will start developing some things like this. So it is good practice to note the blood pressure as the baseline investigation at the time of registration itself. So the new patient's BP should be recorded in the green book at least, and also if possible in the white card. So at least first page of the green book should have all the details like you might be entering at the time of your UG or PG clinics. So patient's history, past history, other histories, then on examination findings, general examination findings, systemic examination findings, genital area examination, all that need to be written on the page 1 of the white card for the new patients. Also, you can draw the X-ray, you can label the findings of the chest X-ray, any additional investigation, any relevant investigations, which is positive investigation, those can be recorded in the first page of the of the green book. That is very important. If you do that as a practice, it will be helpful for the patients in the future, but also it will be helpful for you to retain your clinical skills. If we look at it from the, again, what I explained just now is our Indian system, what we do. In the US, they follow this, and this is also a good way to do. There is another format which is called a SOAP format, in which you SOAP stands for subjective, objective, assessment and planning. In subjective, you ask patients regarding history. In objective, you examine and again assess the findings. In assessment, based on the history and examination finding, you do assessment and come to a differential list of differentials and make your diagnosis. But in HIV, in assessment, other things are also included. Like, it is not only about the clinical diagnosis making, but also it is regarding what is the social status, if there are some addictions, there is a person who is drug injectors, if there is a history of multiple sex partners, high risk behaviors, then patient is alcoholic. All those things can come in assessment, which is and with the assessment you can make a list which is called as a problem list. So there can be 10 problems in a patient. New patient comes in, he can be in depression, he is not accepting, suppose, HIV positive result. Suppose he has TB. Suppose he has some stigma discrimination related issues. He is alcoholic. He has other 3-4 problems. So out of these all 10 problems, this is called as a problem list. You need to prioritize the problem and put it up. So if you prioritize the problem, then it is easier to concentrate on those problems. And that leads to the fourth of the SOAP format, that is subjective, objective, assessment and planning. So you can then plan management for that patient for all those problems based on their priorities. So this is another way of doing the clinical examination and assessing the patients. So that also is very helpful. But problem with us is we will be interested in first two, subjective, objective. And sometimes we will be interested in assessment also. We do try to find out the problem list and all that. Also we see investigation result and all that. Problem comes in planning. We most of the times miss that planning part. We just most of the times work as a mechanical entity, and we just focus on guideline, or we compartmentalize the issues. So that should not happen. When you write down your planning, at that moment, whatever comes to your mind as a clinician and as a physician, you can note those points that this is the plan for this patient. Next time when patient comes in, you can see your own plan. You need not think of all that history which you thought of, all that assessment you already performed, all that planning you already did. So all your efforts will be paid off if you write your plan in the green book also. So that is very helpful. But this is optional. It is not that it is necessary to be recorded in the green book. But if you do this, it is helpful. You try it out. If it is helping you, you can continue using it. So these slides are from, again, Dr. Alex. The nutritional status, BMI, is calculated, and nutritional status is assessed. Vital signs, that is fever, blood pressure, heart rate, is seen. Then physical examination, head, eyes, ear, nose and throat. We see if there are vision problems, oral thrush, oral lesions and others. Then comes investigations. Now all those pre-RT registrations, I've seen a bad practice, I should say, in some of the centers. They, until unless patient comes with all investigations everything, they don't even meet the medical officer. That should never happen. If a person goes to, and see, this becomes a reason for loss to follow-up. If you, in the first visit, if suppose, you imagine yourself going to some hospital and no doctor has touched you, no one has seen you, and you were just advised some investigation and then you were asked to come back after results, will you be interested in going to that hospital or clinic later? I will not be interested in going to that particular clinic later, because my problem is someone has told me that I am HIV positive. Someone has asked me to go to that center for ART. I have reached that center, but no one is talking about drugs. No one is talking about the problems which I have. What happens is, patient goes to the CCC, goes to the counselor. Counselor will say, okay, what's your name and other details. Section 1, 2, 3 is filled. Risk factor, this and that. All those things are done. Green book is made. Then patient, there will be a stamp of investigation. The stamp is put on the green book. Patient is asked to go to the lab technician for an investigation and will be asked to come back with the results. Now this is worst. This should never happen. All patients should go to the medical officer, should be examined in detail before they go to the lab for the investigations. So and doctor should advise the investigation. Though it is a stamp, let the doctor put that stamp, because then it means a lot to the patient. Talk to them properly. New patients, give them time. See, there is a increasing problem of loss to follow-up. We are all are aware that is being seen in the ART centers. The main reason for that is the initial visit. You see the practice at your own centers. If you are counseling, if you are spending more time with your patients who are new, and you try it out at your own center, you spend more time with some patients and you continue what you are doing with the other patients. And if you compare these two patients, the people with whom you spend more time will rarely become lost to follow-up. That will never happen. They don't have any other place to go. They don't like to go to other private physicians and spend money. They wanted to come back to you, and that's why they had come to you. But if they don't get what they are expecting from you, then they'll change clinics. So try that out. Spend more time with new patients, and then see the difference. So these are the list of mandatory investigations which are to be performed at the baseline. Again, we need not wait for, if suppose some investigation is not available at your facility, you need not wait until all investigations are done and reports are with you, and you should not delay ART because of this. Actually, effort should be taken that all these investigations are done soon and fast, but delay should be again minimized. Lipid profile is again not advised in all patients as baseline, but of course, if a person is being started on PI based regimen, lipid profile is required. So other investigations are based on, again, those are called as symptom based investigations, or like if a person is 4S positive, you will do sputum for AFV, or you will do CB-NAT for AFV. Sputum for AFV, but CB-NAT testing. Then having some suppose meningeal involvement, you will like to have CSF analysis done. And then again other investigation like USG abdomen. It is not mandatory in all patients. Sometimes patient they advise USG abdomen in each and every patient, and it is not available in the hospital. Patients will be given appointment after 2 months. So please don't do that. Do the clinical examination. If you feel that this patient requires, in the best of your own judgment, you can do USG abdomen. Don't advise in each and every patient, especially because we don't have facility for in all setups. Even if we have, there is a huge backlog. And don't send in private for USG abdomen if it is not there at your center. Of course, if it is suppose not available, then we find out ways to do it, but not in each and every patient. Lipid profile, if possible, all need to be done, but if it is not possible, then at least triglycerides and LDL can be seen. Chest X-ray is mandatory in each and every patient. Yes, chest X-ray is mandatory. That has to be done. Multiple number of patients with triglyceridemia regardless of their current ART regimen. Going to have multiple number of patients with triglycerides. Yes, see, these days there are, because of many other habits, patients are having irregular fat levels. So that can be found out commonly even in non-HIV people. If you see, most of us will have lipid abnormalities. That does not necessarily mean that it is because of some disease, but it is because of lifestyle. In our center we don't have facilities for lipid profile. Most of the centers, they don't have facilities for lipid profile. So if you don't have, try to get it done. But again, as I said, it is not necessary in all patients. Those patients who are on PI based regimen especially, they will require lipid profile to be done. So if you do not have that, refer the patient to medical college if you really require them. But if it is not, then it is okay. Because what can you do if it is not available? So try to talk to your superintendent and others and try to get it arranged. But these are the things which we keep on trying, but it is not necessary that we will get it in each and every facility. Can it be cause of HIV related metabolic syndrome? Yes, I would say that it can be a reason of HIV related metabolic syndrome, but that is a diagnosis of exclusion. You cannot confirm it. So before labeling it as HIV related metabolic syndrome, you need to rule out so many things. Then there are other investigations like HBS antigen or surface antigen for Hep B testing, then Hep C testing. Especially it is mandatory for PLHIV with history of drug use, and if ALT, that is SGPT, is more than two times upper limit of normal or strong clinical suspicion. Again, it is not available in each and every facility, but wherever it is available, it has to be done. For HCV, again, for all IDUs, it is mandatory. For Hep B, Hep C, also exclude other liver test for liver disease. Yes, if it is available, you can again go ahead and do the investigations. Test to identify chronic active hepatitis for PLHIV with Hep B, Hep C co-infection and other like blood sugar, LFT, lipid profile are to be performed. In terms of investigation overall, if you see whichever investigations are available in your facility, you will have to do. Basic minimum investigation at least need to be done. Those investigations which are not available, try to get it done with, and if they are indicated, try to get them done from whatever means you have at ART facility, and keep on talking to your superiors and SACs and other people, so that slowly these facilities are made available for PLHIV. See, this list is inclusive. We have tried to include everything in this list, but it is not necessary that all investigations will be available at your facility. Now, the fourth step is very crucial in terms of starting ART, that is preparedness counseling. It is said that every patient will undergo at least 3 sessions of preparedness counseling before going on ART, but it has been misinterpreted at some of the places so that patients are called 3 times for counseling, only for counseling, and this causes a delay in ART initiation. See, though preparedness is required, and we understand that ART is not an emergency, patients can be counseled properly and only started treatment on, but the 3 settings, ideally it should happen before, by the time your patient is ready for treatment initiation. In the post-test counseling, one of the aspects of post-test counseling is ART counseling. When patient comes to the ART center for the first time, post-test counseling happens at ICTC. And when patient comes to the ART center for the first time, that is the time when also you should talk about ART. And when patient comes back with the CD4 test results, again you need to talk about ART. So there will be obviously 3 or 4 settings of counseling which already might have happened before patient comes to you, and you can start ART in a day or 2 of registration to the ART center also. So, but while starting ART, please make sure that patient understands what the treatment is. Patient understands that this is HIV and it's going to be for lifelong. Patient understands that ART is once started, it will have to be taken for lifelong without missing a single dose. Patient should understand that there are some toxicities or side effects which can happen because of ART. So these 4 things at least patient should understand. Why I'm saying that patient should understand and participate is because that is when it is called as adherence. There is a difference between adherence and compliance. Compliance is something which you blindly follow. A doctor tells you to do this and you do that, you are compliant. But adherence is something when patient participates in treatment. When patient participates in treatment, that means he understands what is the treatment, and this is only thing which works in a lifelong treatment. So compliance is okay for 3 or 4 days. Even then you don't take 3 or 4 days antibiotics, but you are expecting a patient to take the antiretroviral for lifelong. So that requires some understanding. It cannot be just you tell a patient to take a treatment for lifelong and he or she is taking. That doesn't happen. Someone is getting Nair ART's audio problem. Please check your internet connection. WHO recommendations for ART initiation. Now you are all aware that there is increasing evidence that if you start ART early in the phase of disease, it is helpful for many reasons. It is helpful for not only that particular person, but it is also helpful for the community as such to reduce the transmission of HIV to the others. So at present, the general guidelines of WHO and other international guidelines are start ART at any CD4 count, that is irrespective of CD4 count. The Minister of Health of India, that is Union Health Minister Honorable Mr. Nadda, so he has announced that test and treat policy in the Parliament, and that will come as a policy. So though India in principle agrees to test and treat, that has not been yet implemented in the ART center. So you need to wait for instructions and orders from NACO, who will tell you from when to start this test and treat policy. But at present, we will follow the NACO guidelines of cutoff of 500. But in that also, we need to prioritize people who have CD4 count of less than 350. There are many reasons why earlier initiation is better, because if you see multiple studies like this trial, where you will see that survival is better if you start ART in early phase of the disease, and also Temprano trial. This is again a trial which shows that there is a 44% reduction in severe HIV morbidity in patients in whom you start ART early. So what should we do for our patient? We need to see how urgently should our patient be started on ART. What is an acceptable amount of time for which we can wait before initiation of ART medicines? Do your clinic policies act as a roadblocks? This is what I was trying to mention. Sometimes we have shortage of medicines, sometimes we don't have proper supply, and these are rare incidences which happen where we need to prioritize. So if suppose you have at present the reason for we are not able to roll out from the day one test and treat policy is because again many things have to be seen. The patient load, the increasing requirement of drugs, and all that are to be planned, and that will be done by NACO very soon. So once NACO is ready for that, there will be very soon a launch of test and treat in NACO also. That is going to happen. It is coming, but please wait until you receive instructions from NACO, because it all depends on, if you start without NACO's instruction, then you'll run out of drugs and then you'll not have ART in your centers. So that will be a worst scenario. So from our side, we need to do special evaluation of each and every patient, and what we can do in the meantime is take your active and care on active in care number. I'm not saying all general total ART patients, but at least active in care, that is your 3.10 of your MPR. From that you remove your alive on ART, that is active care is 2.10. Then from that you remove your alive on ART, that is 3.10. Remaining are active in pre-ART care. So try to see where these patients are. Try to contact them. Try to again call them back to the ART center and try to start communication with them. If you bring them back, especially from them, there will be a subset who are medically eligible and not on ART. You need to bring them back also. So these are the patients who are in pre-ART care, but they will be immediately become eligible for ART as soon as test and treat is announced by NACO, and you will receive the instructions regarding that. But before that, please do this groundwork at present. Start calling them, tell your medical office counselors that this is going to come. So we should be ready by the time NACO announces test and treat. We should be ready with numbers first, that how many additional patients are going to be added to our ART patient list. To a general percentage, if you see, there will be 15 to 20% patients will be again added, but it can differ from center to center. Start calling them and call them back if they are not regular in their CD4 testing. At least involve them in care, activate them so that they do not wait to fall ill and then come to you for ART initiation. That should not happen. So utilize this mean time for this groundwork. Towards the end, this is just a summary for what is to be done in a new patient. First is verify the test results that a person is HIV positive through ICTC. That is should be done. Then try to ask questions questions to the patients to know what he or she understands by being HIV positive mean. And at the same time, see, first when patient comes and when you ask about HIV, two things you should add. One is regarding what is CD4. However illiterate your patient is or client is, make them remember this term CD4. If they remember this term and if you tell them that higher the CD4 it is good for you, they will remember. They will, and you also tell them that every 6 months we will see that how your CD4 is doing. They will be happy to remind you that my CD4 is pending. They will happy to monitor their own CD4 count. Each patient of you should remember their current CD4 count. You ask them in random. Whenever they come to you, first question should be, what is your CD4? They will say, okay, what is CD4? I don't know. So that is, if you start asking, they'll know it, they'll remember it, and this is how you improve the participation of patient in the treatment. When it is dropping down, then they only will come to you and say that, sir, my CD4 is coming down. What is happening? Then you can evaluate the patient for immunological failure. All that can be done. So in the first visit, ask what is HIV, tell them what is CD4, and third thing is tell them what is ART. If you introduce these three words to the new patients, it will help you and the patients in the long run. Use a thorough history and physical examination to determine WHO clinical stage. Include stage 4 symptom screening. 4 symptom screening for TB. Then determine whether ART is indicated at present and how urgently the lab results are required. Then treat any comorbidities if the person is having, like STIs, worms and other things. Now STIs, for that you will have to see the genitals and examine genitals, see the skins and detailed examinations. All those things need to be performed in new patients. Start prophylaxis with cotrimoxazole whenever it is indicated. Discuss family planning. Now family planning doesn't mean abortions. Family planning doesn't only mean condoms. It means things which are beyond that. For example, if a young lady comes to you and you know that this lady has a potential to become pregnant, then you need to counsel them in a way that which is the right time to become pregnant. If female's viral load, suppose, is very high, obviously you do not have access to viral load, but you are seeing CD4. If CD4 is suppose 200, what will be the viral load? It is expected to be higher side. That is not a right time to become pregnant. So they can plan in a pregnancy in a way that when a person is on treatment at least for 6 months to 1 year, then the viral load is maybe suppressed to undetectable level. Then the risk of transmission will be very, very low. You respect patients' opinion of having children. Don't discourage them from day one that your children will be HIV negative and all that. Don't put in those negative thoughts in their minds. Be open to thoughts, be open for discussion, and try to understand them first, because everyone will have different priority. If they want to have kids, you cannot discourage from them on day one. So listen to them and help them out in taking their decisions. So that is what adherent from patient side, adherence from the provider side. So you also need to be patient and understanding. You need to explain them in a way they understand, and then they are equipped to take their own decisions. Offer emotional support and counseling. That is emotional support will not be required for each and every patient. You don't start on negative note when a person comes to you. Start on a positive note. Assess the person's situation. Give them what they need. Don't use a single formula for each and every person. Sometimes, as I mentioned, patient will not be worried about HIV. They will just come to you like that. But then when you start asking things which are then they'll become like, oh, this is something which I should be worried about. So don't introduce your own worries in their mind. So that should not happen. Talk to them and discuss with them, give them what they require. Past history of TB before registration in ART, then what we should do, start ART or not? You should start ART. See, TB history in history of TB at any time in life, past history at any time, patient becomes eligible for ART. Now HIV positive, you need to start, patient becomes eligible for ART, and you can start ART in them. We'll discuss again this when we discuss TB session. So that is all what I wanted to discuss with you. I know that this is not exactly what I have tried to include more of Indian perspective or our program perspective in this clinical contact session. If you have any more questions, you can post them, we can discuss now, or you can post them in WhatsApp group, we can discuss later also. Okay, if not, okay, CD4 less than 50, start ART and ATT simultaneously. Yes, we need to start them simultaneously, but that doesn't mean that both the tablets need to be taken on the same day. It means that you started TB treatment, next day you can start ART, but it can be done within first 2 weeks. So that is what simultaneously mean. Go for CB NAT, evaluate for TB, give Septran if 4S is positive. Okay.